Good afternoon, everyone. Having a session immediately after lunch, I'm beginning to understand what health professionals were feeling before the pandemic, which is a neglect and a lack of attention. But I'm really pleased to be doing this session today because in many ways it's really one of the most crucial issues facing us. The word unprecedented has become an overused word. But 2 years ago, no one could have predicted that entire world economies would come to a halt, that human traffic would actually stop, and that 7 billion people would collectively fear a word as simple as the wave. But having gone through that devastating experience, the thing to really ask is, what are the lessons we have learned? And we are not even entirely out of it. So the focus of our session today is going to be, what are the lessons, what are the psyche shifts, what are the priority shifts, the policy shifts, and what have been some of the triumphs, and in keeping with the theme of the conclave, what shape can a better normal take? To answer those questions, we have an exceptional speaker today. Sir Malcolm Grant has been the Provost and Vice Chancellor of Cambridge University, University College of London. He's currently the Chancellor of York University. But his most crucial intervention has been to be the founding chair of the National Health Services in Britain. The NHS is deemed to be like a religion in Britain, more sacred, more trusted than the BBC, the monarchy, and religion put together. So in a way, you could say we have the Pope of British health here today. He, when he was the chair, presided over a budget as large as $130 billion annually, and he played a huge role in shaping the NHS. He's also the head of a Plus Alliance, which is a coming together of the University of New South Wales, York University, and Arizona State University, and their focus is on sustainability, public health, and the intervention of technology in creating a better world. So thank you very much for joining us, Sir Malcolm.
Shoma, it's very good to see you, and thank you so much for the invitation. Good afternoon to everybody in the hall.
So Malcolm, let me start with the first question, which is that in many ways you've been in the belly of the beast. You have access to everyone who's been in the war zone. Sir Simon Stevens, who's declared like a war hero in Britain, was your protege. So the first question is, have we turned the corner? Are we over the worst? Or are we still going to face a third wave?
I think it's a really difficult question. I think we are turning the corner. But I wouldn't underplay that this is still a raging pandemic. It's still a raging pandemic across the world. We're seeing death on a scale that we've never seen before. And when I look at the daily charts that come from what I think is the most reliable source, which is the Johns Hopkins University Coronavirus Dashboard, it leaves me still with some quite deep concerns. We're seeing, even in the United States, about 53,000 deaths per week from this pandemic. In Europe, the incidence of cases has continued to remain quite high, but the hospitalizations and death rates have come down. And this is quite reassuring because it shows pretty much the impact of the vaccines on our populations, and vaccine rates have gone up significantly. But we are at risk of normalizing death on a grand scale if we're too complacent about having turned a corner. For me also, I think the big challenge for the coming weeks is winter in the Northern Hemisphere, when our populations are more inclined to be indoors, where transmissibility could be greater, holds out a big challenge for all of us in the Northern Hemisphere. We're in the UK at the moment now quite worried about winter flu, which we have seen, shall we say, lowered immunity rates to as a consequence of the pandemic of the past 2 years. So yes, we're turning the corner. And I'm really reassured by some words recently from Sarah Gilbert, who was the Oxford professor who led the pioneering AstraZeneca vaccine, who says, well, in due course, this is going to be like the common cold. We'll grow used to it, and it will have no greater winter or summer incidence than the common cold. But we're still a long way to go before we get there. There's still too much about the virus that we frankly just don't understand.
So Malcolm, in fact, that's another statistic I'd like to throw, that in fact just this week, UK still has gone up to 40,000 cases, which is different from what it was just a month ago. And as schools are opening up, there's a kind of, even asymptomatic cases are on the rise. But so, the unpredictability of the disease has been something that all leaders across the world have grappled with. And we spent the better part of 2 years really griping at all our leaders, but also understanding that it's a truly difficult situation. But if you were to pick the 3 top leadership lessons, the mistakes that leaders have made, what would you pick?
I think mistake number 1 was not taking it seriously. Right at the beginning, this thing that we sometimes call British exceptionalism, which is that we are unaffected by what happens in the rest of the world. And it's a very selfish, inward-looking concept. But we could see in February 2020 an exceptional peak of cases in Italy. And this just wasn't the impoverished part of Italy. This was one of the wealthiest parts of Italy, up in the north. And that should have triggered an immediate response.
Forgive me for butting in, but that particular mistake of not taking it seriously is well known. So I'd ask you to pick something which is, something which is a bigger takeaway, because by now we all know that no one took it seriously till it really hit us.
Well, I think it's related also then to the political response. I think that our government in Britain underestimated the willingness of the population to buckle down and to agree to a lockdown. So there was hesitancy. And also, Shoma, I think coupled to hesitancy is uncertainty and mixed messages, failures of communication. And I know this is true across the world, where the government of the time demonstrates that it doesn't seem to be on top of it, doesn't seem to understand. And this is complicated stuff. The science was really complicated. And it's not just the science, it's the risk profile. And governments across the world took time to do it. But let me give you one example of the challenges that we faced in the healthcare system. And by the way, of course, I was no longer in a role in the NHS over the last 2 years, but we looked at what was happening in China. And you may recall in China, rapid lockdown, and then with military help, building fantastic new hospitals. Hospitals sprung up out of the ground overnight. And for us, that then proved to be, shall we say, a competitive challenge. So we created hospitals, we created Nightingale wards. The military came and set up 2,000-bed hospitals within the space of a week. We hardly ever needed them. But that to me demonstrates that you can make something that in retrospect looks like a mistake, but at the time was a vital insurance policy. So I've got some sympathy with political leadership in all of this. We will make mistakes always, but the question, Shoma, is this: what have we learned? What could we do better next time?
So Malcolm, in fact, that brings me to the next question, and I'll move quickly to looking at the future. But there's this prevention paradox that leaders have really faced, which is that when we invested in infrastructure and then you prevent the mishap from happening, then there's a lot of sense that that's wasted expenditure, that someone overcalled it, and there's a disgruntlement even there. And then you kind of dismantle that infrastructure. It's seen as wasteful spending. So how do you get around that? That if you set it up and you prevent the disaster, then that's also called a mistake of leadership, because you never know how bad it will get.
Yeah, I would say one of the big things to be doing for the future is investing in the science. I mean, let's look. I mean, the triumph of this pandemic has been the vaccines. And none of us foresaw how quickly we could develop those vaccines. I remember giving a speech in London back in March last year and having to say vaccines are at least 2 years away. Well, they're not. They've been remarkably produced. We've vaccinated, I think, something like 7 billion doses of the vaccine have been administered across the world. So I would say that's something that if we don't seize on that, if we don't now invest in further vaccine development for the future, then we've really lost the opportunity. If we can understand that science offers us a way out of the black hole of these terrible, terrible viruses, then we've missed a real opportunity.
Sorry, Sir Malcolm, some of your voice is dropping, so I'm having a little bit of trouble hearing you. But, broadly, I got what you were saying, which brings me to the sense of the expenditure and the spending, the priority that we give our health spending. So, I mentioned at the beginning that you sat over $130 billion budget for NHS. And yet, there was difficulty in dealing with this, So, but just in terms of priority, and when you were mentioning that 7 billion people have been, that vaccines have been made available, I do want to share that though India went through a crazy, very, very devastating second wave, and there were a lot of mistakes made by the government, but 5 months later, India has administered 930 million vaccines, The US has done 400 million, UK has done 94 million. So can you help us understand a little bit, looking forward, that India just spends 1.2%, now it's gone up to 2.5% of the GDP on health, that what are the differences? What's the outcome? How much does UK spend? How much should India spend? And what is the outcomes we're looking at?
Gosh, that's such a big question. I could talk to you for a long time about that. Look, there's no optimal figure. America wastes huge amounts of money on healthcare. America spends something like 18% of GDP on healthcare. And yet, if you look at the health profile of the United States, it's no better than the health profile of many countries that spend half that amount. India is going to have to invest more. There's no doubt about that. And to my mind, one of the lessons from the pandemic has been its incidence on people who have underlying serious health conditions. And in much of the Western world, those health conditions are reflected in obesity and in the type 2 diabetes that's so often associated with it. And this is where hospitalizations have occurred and a high mortality rate amongst vulnerable populations. So we need to invest more in our healthcare systems to try to improve the overall health of our populations.
Malcolm, if you just hold on for a second. Are you all hearing a drop? Because I'm really finding it hard to follow what he's saying. Is the audience having a similar drop? Yeah. I'm sorry, Sir Malcolm. I'm just going to refocus that question. I'm also having a bit of difficulty hearing you. So,
I apologize. The sound is faulty.
Can we just hear your take on how much the UK spends on health and what the NHS has got right? It's government expenditure. So are there any lessons that, say, India or any other country can learn from the way the NHS has been run and constructed and how much spending is done on it?
You opened our session by talking about the NHS as a national religion. And there's a great sense in which it's a community enterprise in the UK. And that's not common across the world. Secondly, we spend about 8 to 9% of GDP on healthcare. Across Europe, it's more like 11%. If I look at the Nordic companies in France and at Germany, Nordic countries, France and Germany, there's no optimal figure. The real question is, how do we get high quality healthcare at lowest possible cost? When I look at India, it's obvious that more money is going to need to be invested in healthcare. But how can you use the technological advantages of India, particularly in relation to data, to leapfrog over some of the more customary models that we have in the UK and in the Western world? To me, much of the future of healthcare is going to be about data. How we understand and profile the health of the population, how we use data and AI to develop new drugs, and how we digitize, for example, imaging and its interpretation. I think these things are going to hugely improve the quality of healthcare. India's got an opportunity, without imagining that it needs to move to 10% of GDP, an opportunity to make significant change in what is already being done.
So Malcolm, I'm going to come to what India is doing, and the Prime Minister's just announced the National Digital Health Mission, and I want your perspectives on that. But earlier when you were talking about the NHS, when we were chatting earlier, you said a couple of the things that is really done right and which eventually the leaders did right was to build trust, was to have daily communication, to have scientists standing next to you, to really bridge that trust deficit that had built up between the population and the leaders. And also, it's not so much in terms of the sheer spend, the budget spend, but you'd spoken about something very interesting, which was the priority and the percentage of spending. So you mentioned that UK, the second highest government spend in the entire budget is on health. And I found that a very interesting statistic, more than the actual numbers. So I just wanted to put that out for our audience. But now coming to this thing that you just said about digitization, technology, intervention. Prime Minister Modi has just announced the National Digital Health Mission. Pilot projects are being rolled out. What do you think the shape of that mission should take? There is some concern about, data privacy, the fact that India is a very plural country. There's great digital divides, there's communication divides, there's capacity divide. How will patients explain themselves? There are many remote areas where people find it very difficult to even explain their diseases. So there's all of that. And the question I'd like to put to you is that in 2011, the NHS wrapped up its digitization scheme because it was a failure, and it was deemed the most expensive mistake in IT history, So how do you sort of correlate the two things?
Well, all of the features that you mentioned in relation to India are exacerbations of what also exists in the UK, the divide, the population scattered and remote, etc. You refer to the experiments that led up into 2011, and yes, it was a disaster because it wasn't well procured. Procurement lies at the heart.
I can't hear you. You said it was a disaster because?
It was badly procured. Too many companies were trying to do it and competing with each other, and it was underfunded. And by the way, procurement has been a disaster in many countries through this pandemic. But let me come back to the digitization. You mentioned this question of trust, and it's absolutely critical. Every time we try to expand the use of patient data in the UK, the question of trust comes up. How can we trust our government with data? I think people are willing to trust the NHS and doctors with their personal data. And we need to break through some of the privacy barriers to ensure that data follows the patient in whatever care setting they find themselves. But what we need to be able to do is have much more transmissibility of data across the system so that we can deploy new data methods of diagnosis and therapies, but at the same time retain people's trust. And I think it's doable. I don't think this is rocket science, but I think the answer has to be it's the patient who controls the use of their data. You talk about, of course, the digital divide, and that's absolutely true, but look at the pace at which digital phones and smartphones have rolled out across India, and a pace that I think has astounded the rest of the world. These are not impossible things, they take time. And the pandemic, to me, has demonstrated the critical point about trust, which is that our populations don't necessarily trust our politicians. They do tend to trust our doctors, and they do tend to trust our senior scientists. And they've been the bridge between government and the people, certainly in Britain.
So, just taking that further, there is a huge human resource gap between what we need, particularly in India, and the health services that are available. So there is a great need for, for telemedicine, for digitization. We've also seen, after a bit of, stumbling in the beginning, our CoWIN app has worked pretty well. But a very interesting aspect of that was a kind of hybrid format, which is that there is digitization for those who can access it, but there's also great focus on those who can't access digital technology, so it's a kind of hybrid model. So I know that you're, even with the Plus Alliance, very focused on what a health force of the future of the 21st century should look like. So can you map out 3 or 4 very important components of what a future health force or a future health policy should ideally look like?
Yes, thank you for that question. I think 2 or 3 things. First of all, what is the healthcare workforce of the future going to have to do? Building on my comments earlier, we should no longer be investing all of our resources into fix and repair of ill health, but diverting these resources upstream to try to ensure that people don't fall into ill health in the first place. Also, I can see new technologies coming through that will allow us to have much earlier detection of disease in a population and in individuals. What we therefore need to do, number 2, I think, is to train a new workforce, remembering that our workforce is now going to come from a much more digitally educated population. The young people who have never had a world without a smartphone don't want to work in a paper-laden environment where the data that they need about a patient is at the bottom of a pile on somebody's desk. So I think that taking advantage of the digital education already of our workforce as they come into the workforce is going to be important. And then thirdly, that means that the way in which we shape their training has to be not just in the hospital, but out in the community, out in those remote areas you just talked about. How do we link up access from those remote areas through telehealth and other models through to world-class centers of excellence? That to me is much of the future. Just one anecdote here. At the outset of the pandemic, our general practitioners in England, population 55 million, were having 1 million patient appointments every day. Within 3 weeks, that had transferred to 90% remote. They were doing their business remotely. And although that proportion has come down again, it has set a tone for the future. We can do some very accurate healthcare without actually the physical examination of the patient in every case.
So, the other aspect of this is AI and sustainability. So, again, to focus on the models that you're working on, are there any pilot projects that you all are running which has weeded out some of the difficulties that we are talking about? What can AI do? During the pandemic, we had one big trouble zone was, again, about data sharing. So there's, again, a riddle between the need for data sharing, scientists wanting access to it. In India, largely because we haven't thought through these issues, the government wasn't sharing data in real time, so genomic sequencing couldn't be done. And at another level, what we've already spoken about is that there are big concerns about privacy issues, who will have access to that data. So are there any, and you've already talked about the fact that UK already had a disastrous experience with this. So is there any sort of small model project that you all have designed which, countries can learn from?
I think one of the most impressive ones during the course of the pandemic was set up originally at Oxford University, and it was called the Recovery Trial. What they eventually did was to network 183 hospitals across the UK and around the world, Indonesia and Nepal are now part of this network, and able to do real-time data sharing on clinical trials for the treatment of patients being hospitalized with COVID. A remarkable breakthrough was tamoxifen, where they discovered that this had a significant reduction in mortality for patients who are being ventilated. So this is the use of a repurposed steroid. But you could only do this by doing it across a wide number of hospitals and sharing the data. Now, you couldn't always get patient consent because the patients were by definition unconscious, but you nonetheless were able to demonstrate that the sharing of data on this scale was critical in real-world trials to understanding outcomes, which have helped to save thousands of lives.
Right. So just one other discussion about the economic aspects of this, that, we've learned now through the pandemic that we don't treat health with a kind of priority, but it creates low productivity, economies ground to a halt. So we've really seen the true cost of that health. So in terms of a country like India, I know that the Plus Alliance is wanting to bring projects into India. Even at a state level, what do you think? Have you done any modeling on what health expenditure should be? What should be the numbers of our workforce? Should there be more focus on technology? Just specifically on India, what are your thoughts?
I think on India,
the cost versus the benefit.
On India, the complexities are enormous, as you know far better than I do, and the state variations are very significant. It seems to me that what is needed is very clear central government leadership, but also strong state leadership. And one of these issues that follows from that is that you'll often get quite differential performance in different states. And that, I think, is the price that we have to pay for encouraging the devolution of responsibility to the level where it actually can work. And of course, social conditions are different in each of the states. So I'm hesitant to offer any sort of overall clarity about it. But two things stand out. One is that the level of investment in healthcare in India is remarkably low for a nation whose economic growth is much greater than it used to be. And if I compare it with other nations around the world, it's clear that further investment is needed to be put into it. But secondly, it doesn't all need to come from government sources. The private sector, as we see in America, can be an enormous driver of change and of improvement in healthcare systems. I don't want to go into positions in individual states because I certainly do not have the intellectual coverage to be able to do that. But from my experience elsewhere in the world, what is so important is that this is not about hospitals, it's not about equipment, it's not even about money, it's about people. And it's the dedication of healthcare professionals that makes the huge difference between effective health systems and ineffective health systems.
So just to end on, Sir Malcolm, there are two other paradoxes. One is that when we are, sort of admiring the model of the NHS, that's a highly, in a way, centralized, unified, homogenic structure, publicly funded by taxing people. I think 90% of it is funded by public taxation. And it's clearly a good model. But in India, we're going the opposite way, which is of extreme privatization of health. But, Adar Poonawalla was supposed to join us. We've seen how he pulled through for us. 80% of the vaccination that's happened today has come out of the Serum Institute. So, there are success stories in all models. But the last paradox I want to ask you about is, now that we're moving forward, having gone through this devastation, what should the focus be on more if we have to really prioritize something? In terms of public health, should the focus be on prevention or on treatment, on infrastructure or on programs? Where would you place if you were to sort of weigh in on that? Where should the balance lie?
So first of all, just to say, I am a huge fan of the Serum Institute. And what a helter-skelter ride Mr. Poonawalla has had over the past couple of years. So let me just record the world's thanks to the Serum Institute. To answer your question directly, it's inevitable that we've got to focus much more on prevention. Our healthcare systems are from the 1940s and 1950s, and their model was to intervene where life was seriously at risk. We can't operate like that. And one thing that really I have learned from this ghastly pandemic is the investment in public health and population health has to be a major priority for our future. It's population health in the sense of trying to protect people from such horrible diseases in the future. That involves investment in science, but it also involves looking at why our populations are growing fatter, why they are more vulnerable to ill health. And as they age, why isn't it people are aging healthily and not just aging as a fact? So there's an enormous amount to do for government for the future. Also for the private. No system in the world can operate without public funding. Otherwise, you'll get huge disparities. Even in the United States, half of the healthcare expenditure comes from the government. It's a myth that this is entirely market-driven. Governments are there to drive out wide disparities in the quality of healthcare and in the health of the population.
Just when you said population health, what exactly did you mean by that, Sir Malcolm? Can you quantify that or talk about something specific? We are focusing a lot on therapeutics, but what is population health?
Well, let me put it in terms of an expression that's often used, which is the social determinants of health. And health is not simply a factor of our genes, and it's not simply a factor of our healthcare systems. Best estimates are that the health of a population is only dependent to about 15% on the healthcare system. What's much more important are the environments in which we live, our diet, our nutrition, our exercise. All of these are factors which help to reduce the incidence of cardiovascular disease, for example. And these are areas where governments have been largely neglectful of the health of the population. So we need a revolution. We need an absolute revolution. And you will notice, of course, a very strong correlation between poor diet and poor sanitary conditions and poverty. And these require a sort of holistic approach from governments, not focusing solely on healthcare in its formal sense.
Thank you very much, Sir Malcolm. We'll leave it there for now. It's, this whole hybrid format allows us to communicate, but I'm kind of finding a metaphor in this for our takeaway message, which is that, we need that hybridity, because while technology is enabling us to do this, there's nothing like face-to-face as well. So I hope going forward that in the 21st century, as we're shaping our health doctrines, that our governments will focus on both aspects of it, and we've seen the economic cost of health. So my biggest takeaway from this really was the fact that health spending in the UK is literally its second highest priority. So thank you very much for joining us, Sir Malcolm. It's a pleasure.
And thank you very much for the opportunity to do so. It's been very, very enjoyable. Thank you.